Hello everybody. Today we are going to discuss approach to the tropical fever. So tropical infection can guide the intensivists regarding the commonest etiology, investigative modalities and help them to choose early empirical therapy. So for age of diagnosis, these infections were divided into five major symptoms. One is undifferentiated fever, fever with rash and thrombocytopenia, fever with ARDS, fever with encephalopathy, and fever with multi-organ dysfunction syndrome. So undifferentiated fever can be seen in malaria, scrub typhus, leptospirosis, typhoid, dengue, and other common viral illness. Fever with rash and thrombocytopenia is common in dengue, rickettsia infection, meningococcal infection, malaria, lepto, measles, rubella, and other viral exanthem. Fever with ARDS is seen in scrub typhus, falciparum malaria, influenza including H1N1, leptospirosis, hantavirus infection, and melioidosis. Then severe community acquired pneumonia is caused because of the Legionella, Streptococcus pneumoniae, diffuse alveolar hemorrhage due to collagen vascular disease. Then febrile encephalopathy is caused because of the encephalitis like herpes simplex virus encephalitis, Japanese B, and other viral encephalitis. Then meningitis is caused because of the Streptococcus pneumoniae, Neisseria meningitis, H. influenza, enterovirus, scrub typhus, cerebral malaria, and typhoid encephalitis. Fever with the multi-organ dysfunction is seen in bacterial sepsis, falciparum malaria, leptospirosis, scrub typhus, dengue, hepatitis A and E, with fulminant hepatic failure and hepatorenal syndrome, hantavirus infection, hemophagocytosis, and macrophage activation syndrome. So this is the algorithm for the approach to the tropical infection. So first we have to assess and stabilize airway breathing circulation, and then we have to identify the red flag features like if we need to see if the patient is in surge response or not. Then next step is to identify the focus of infection. If the focus of infection is identified, then treat accordingly. Like if it is pneumonia, like focus of infection can be pneumonia, pyelonephritis, any abdominal source or cellulitis. Then send appropriate investigation according to the focus and start with the empirical therapy. But if the focus of infection is not clear, then assess the clinical syndrome and consider risk factor. Then we need to extract the another history like geography, season, and any associated symptom. Then we need to classify this whether this is fever with rash thrombocytopenia, whether this is fever with jaundice, fever with predominant respiratory syndrome, or fever with MODS. So if it is there, consider tropical infection and send essential blood culture to sets, then other routine investigations like complete blood count, platelet, electrolyte, CRP, creatinine, liver function test, urine analysis, chest X-ray. Then conduct the rapid diagnostic test like malaria card test, dengue card test like for NS1 antigen, IgM, IgG, typhoid and H1N1. So if a rapid test suggests the diagnosis, then treat accordingly. Like if it is positive for malaria, start with the injection artesunate 2 to 4 mg per kg at admission, then at 12 hours and then 24 hours once in a day. If it is dengue, start appropriate fluid therapy, consider supportive therapy for bleeding, electrolyte abnormality, and if it is positive for typhoid, then consider giving injection ceftriaxone 100 mg per kg per day. So in empirical therapy, we can start injection ceftriaxone 100 mg per kg per day, tablet doxycycline 5 mg per kg per day, and tablet AZI, and then we need to wait for the further workup. And we can also consider the USG abdomen and bone marrow examination and culture. So if it is a fever with encephalopathy, assess and support airway breathing circulation, obtain blood glucose level. If it is low, then treat with dextrose. If it is high, start insulin infusion. Assess the hydration status. If a patient is dehydrated, give the normal saline. Then if the patient has throat seizure, then start to give the anti-epileptic medication. Obtain good history, physical examination. Then focal sign and feature, then assess for the focal sign and the features of the raised ICP. If features of raised ICP is absent, then will go for lumbar puncture, and if it is associated with a raised ICP, start the measures for the raised ICP like mannitol and 3% normal saline, and consider neuroimaging. But if the patient is not showing any features of raised ICP, consider lumbar puncture and send the all necessary investigation like routine microscopy cultures. Also consider for the TB and send the appropriate investigation. Then we can send the other investigations like ABG, complete blood count, electrolytes, renal function test, liver function test. And if malaria card test positive, then suggest the RT. We can start the preemptive therapy for the meningitis like ceftriaxone and acyclovir, and consider the Vidal serology for scrub typhus, leptospira, dengue, Japanese encephalitis, and herpes, and send and treat accordingly. So if it is fever with thrombocytopenia, we can start with the antipyretics for control of the fever. We can give IV fluids, stop all the antiplatelets, anticoagulant, watch for bleeding. Consider platelet transfusion if the platelet count is less than 10,000, and if it is less than 20,000 with bleeding, there is no role of the steroid. If it is fever with jaundice, start with then fever antipyretics for the control of fever. Start with ceftriaxone 2 gram IV BD, doxycycline 100 mg BD, IV fluids, and watch for urine output, seizure, encephalopathy, bleeding. If it is fever with the renal dysfunction, start the same therapy. Empirically, we can start with ceftriaxone, doxycycline, IV fluids, and also watch for the encephalopathy, bleeding, seizure, ARDS. The fever with encephalopathy, then, as I mentioned before, consider LP, and if it is a patient is showing the signs of raised ICP, then start the measures like mannitol and 3% saline. Then, if it is a fever with the ARDS, then uh, give the lung. If the patient is not ventilated, then start the oxygenation by Venturi mask or NIV. If the patient is ventilated, consider lung protective ventilation. And in this case, we can give the additional coverage for H1N1 in the form of tablet oseltamivir. And for a typical coverage, we can add tablet azithromycin. And then, according to the diagnosis, we can initiate the specific therapy. So if the scrub typhus is positive, then the causative organism for the scrub typhus is Oriental Sutsup which is caused by the shivers. The outbreaks are reported from all over India, starting from the sub-Himalaya belt to more eastern and south Indian regions. Regarding pathophysiology, organism will affect the vascular endothelium with subsequent vascular injury in organs like skin, liver, kidneys, meninges, brain, resulting in multi-organ manifestation. Then the incubation period for this is 1 to 3 weeks, and it is characterized by the fever, headache, myalgia, breathing difficulty, delirium, vomiting, cough, jaundice, etc. Then complications, it can produce the complications like pneumonia with ARDS, then hepatitis, septic meningitis, myocarditis, and DIC. Lab diagnosis is conducted by Well-Felix testing. Then indirect fluorescent antibody is gold standard. ELISA for immunoglobulin G and IgM antibodies. The sensitivity and specificity for ELISA is more than 90%. Then for treatment purpose, we can start with doxycycline 100 mg BD for 7 days. We can also give azithromycin, rifampicin, chloramphenicol as alternative in children and pregnant women. Then the second tropical infection is leptospirosis, which is caused by the Leptospira interrogans. Source of infection is the direct contact of the skin or mucosa with water contaminated with urine or body fluid of the infected animal. Peak incidence is seen during rainy season, and it is found in the Rampton in southern, western, and eastern. Increasing incidence in the non-endemic northern India. Pathophysiology, leptospirosis multiply in the small vessel endothelium, resulting in damage, vasculitis, and clinical manifestation. So incubation period for leptospirosis is 5 to 14 days, but can be 72 hours, 2 months or more. Then it is associated with the biphasic clinical reaction, clinical presentation, like icteric leptospirosis, which is characterized by abrupt onset of fever, chills, headache, myalgia, abdominal pain, conjunctival suffocation, and transient skin rash. And then icteric leptospirosis, which is known as Wales disease. It occurs in 5 to 15% of cases, and it is characterized by the jaundice, proteinuria, hematuria, oliguria, anuria, pulmonary hemorrhage, ARDS, and myocarditis. Diagnosis is mainly by the raised creatinine phosphokinase level. Then we can send the cultures like blood culture, CSF culture, urine culture, and positive serology. Microscopic agglutination testing, IgM ELISA, sensitivity is 52 to 89%, specificity more than 94%. Then for the treatment purpose, we can start with penicillin G, 1.5 mu, 6 hourly for 7 days. Then alternative, we can start with third generation cephalosporin, oral doxycycline in uncomplicated infection, plasma exchange, corticosteroid, and intravenous IgG in selected patient in whom conventional therapy does not elicit a response. Then dengue causative organism is dengue virus serotype. Then vector is Aedes mosquito. Dengue is endemic throughout the India with recent resurgence of epidemic over past 2 decades. Then the cross pathogenesis, cross reactive anti-dengue antibody from previous infection, enhance new infecting strain with the with viral uptake of monocytes and macrophage, amplified cascade of cytokines and complement activation, endothelial dysfunction, platelet destruction, and consumption of coagulation factor, plasma leakage, and hemorrhagic manifestations. Incubation period is 4 to 10 days. Dengue fever is characterized by the headache, retroorbital pain, myalgia, arthralgia, rash. Then dengue hemorrhagic fever is characterized by thrombocytopenia, uh, skin, skin mucosal and GI bleed, third spacing, and rising creatinine. So diagnosis is done by the NS1 antigen, IgM, IgG serology. Treatment, we can give isotonic fluid infusion just sufficient to maintain effective circulation during period of plasma leakage guided by serial hematocrit determinations, and blood transfusion is done only with the overt bleeding and rapid fall in the hematocrit. Then the next is malaria. Malaria is caused by the Plasmodium protozoa, and it is caused because of the Anopheles mosquito. Plasmodium species are unevenly distributed across the India. Orissa, Chhattisgarh, West Bengal, Jharkhand, Karnataka contribute to the most to the endemicity. So regarding pathophysiology, mechanical microcirculatory obstruction is caused by cytoadherence to the vascular endothelium of parasitized RBC and sequestration. Then it will cause intravascular hemolysis. Then pathophysiology, mechanical microcirculatory obstruction caused by cytoadherence to vascular endothelium of parasitized RBC and sequestration, and it will be responsible for intravascular hemolysis. Clinical features are paroxysms of the fever, shaking, chills, sweat, occur every 48 to 72 hours depending on species. Hepatosplenomegaly may be present in manifestation of severe malaria like cerebral malaria, severe anemia, hypoglycemia, metabolic acidosis, acute renal failure, ARDS, shock, DIC, hemoglobinuria, and hyperparasitemia will be seen. Then manifestation of severe malaria is as then diagnosis is carried out by thick microscopy, that is thick smear for parasite detection, thin smear for species identification, and quantitative Buffy-Coat test. Then rapid diagnostic test, histidine-rich protein, lactate dehydrogenase antigen-based immune chromatography, sensitivity and specificity is more than 95%. Malaria is ruled out if two negative RDTs are there. Then therefore treatment purpose, artesunate is drug of choice. We can start in the dose of 2.4 mg per kg IV bolus, then every 12 hour and 24 hour, followed by once a day for 7 days, and doxycycline 100 mg BD for every 12 hours. Alternative is quinine 20 mg per kg loading dose followed by 10 mg per kg IV every 8 hourly plus doxycycline 100 mg every 12 hours. Clindamycin is recommended in place of doxycycline if the pregnant ladies and children. Exchange transfusion is the treatment of choice for parasitemia more than 10%. Then the next is enteric fever. Causative organism is Salmonella typhi and Serovar paratyphi A, B, and C. It is transmitted by contaminated food and fever. Most prevalent in urban areas, high incidence in children 15 years of age and younger. Pathophysiology, bacteria spread throughout the reticular endothelial system and in areas of great macrophage concentration, such as Peyer's patches. Clinical feature, incubation period 1 to 14 days. Then manifestation, first week it's caused by fever, headache, and relative bradycardia. Second week, abdominal pain, diarrhea, constipation, hepatosplenomegaly, encephalopathy. Third week, intestinal bleeding, perforation, moles. Then diagnosis is done by the Typhi dot. Sensitivity is 95 to 97%, specificity more than 89%. Vidal test is non-specific. Blood culture gold standard positive in 40 to 80%. Bone marrow culture sensitivity 80 to 89% may remain positive even after 5 days of pre-treatment. First line treatment for typhoid is ceftriaxone 50 to 75 mg per kg per day for 10 to 14 days to cover Salmonella typhi. Azithromycin and ciprofloxacin are alternate. Consider dexamethasone 3 mg per kg followed by 1 mg per kg every 6 hourly for 48 hours in selected cases with encephalopathy, hypotension or DIC. Then the next is Japanese encephalitis. Causative organism is Japanese encephalitis virus. Vector is Culex tritenorinchus, and it is prevalent in southern, center, and northern eastern Indian states such as Uttar Pradesh, Haryana, Bihar, Maharashtra, Andhra Pradesh, and Tamil Nadu. So virus reaches the central nervous system through leukocyte and it affects the various part of the brain to cause vascular congestion, microglia proliferation. Formation of the gliomesenchymal nodule, focal and confluent areas of cystic fibrosis and cerebral edema. Clinical feature, incubation period averages 6 to 8 days and range of 4 to 15 days. Prodromal period, fever, headache, vomiting, myalgia. Neurological feature ranges from the mild confusion to agitation to overt coma. Parkinson-like extrapyramidal signs are common, including mass-like facies, tremors, rigidity, choreoathetosis, movement. Then diagnosis is done by the IgM capture ELISA. Then the serum sensitivity is 85 to 93%, specificity 96 to 98%, CSF sensitivity is 65 to 80%, specificity 89 to 100%. Treatment is supportive like airway management, seizure control, and the management of raised intracranial pressure. Thank you, guys.